Hi, everyone. This is Dr. Brian Glass, and this is another episode of the Diabetes Voices of Strength podcast. I am very honored to be joined today by Ranelle Kirchner, who is not only a chef, a dietitian, and a certified diabetes care and education specialist, but she's also the author of two books, at least that I know of. Maybe there are more. Gestational Diabetes Cookbook for the Newly Diagnosed, and the 30-minute pre-diabetes cookbook. So welcome, Ranelle.
Thank you so much for having me, Brian. It's a pleasure to be here.
Great. It's great to have you here too. So tell us, let's start from the beginning. Tell us about yourself and what
Mhm.
led you to become a certified diabetes care and education specialist.
Well, I actually started in food cooking, and it was my experience working in France that kept leading me back to, okay, why do people make these decisions? How do we get people to eat healthier? And I really didn't think people would listen to a chef right away, fresh out of school. So I thought, I need to go back to school, get more education, cooked my way through a few different degrees, and in the process, I was running kitchens, but my mind just kept going back to like, oh, I really want to be working with this population. What can I do more of? Because when I was meeting with patients one on one in my private practice, everybody kept saying, how do I eat better? How do I help my diabetes? And so I thought, I need again more education. So I became a diabetes educator, started doing more one-on-one appointments, and then here I am now. Now I'm working at Southside Community Health Services. I'm their program coordinator for chronic conditions. So I see patients both with diabetes, but with other big chronic conditions as well, like hypertension or chronic kidney disease.
And tell everyone where you're located.
Mm. Yeah, so I'm located in Minneapolis, Minnesota.
Okay, perfect, perfect. And so
Mhm.
how long have you been a certified diabetes care and education specialist?
I'm getting close to 10 years.
Okay. Well, that's great. That's great because you've had a lot of experience and seen a lot of patients. So that is excellent. Was there a particular patient or maybe an experience that inspired the career other than just, I want to make a difference. No one's listening to me necessarily as a chef? Who
Mhm.
inspired you to do this or what inspired you?
Well, I have many family members who have diabetes, and knowing that diabetes gets passed, through our generations, I wanted to be more proactive and try to prevent diabetes. And a lot of my family members started coming to me with their questions, talking about their medications. What do I do? How do I afford them? Because it's very expensive to have diabetes. And so I would say it just kind of fell into my lap. I was curious about it. I wanted to try to keep it at bay in my own personal life. And I think a lot of people do that for different career paths.
Sure, sure. So, most of the people in your family do they suffer from type 2, gestational, type 1? What are we talking about?
Great question. Type 2
Okay.
diabetes.
All right. So,
Mm-hmm.
mainly type 2 diabetics. Yep, absolutely.
Mm-hmm.
And again, the family connection is all important. What type of diets do you focus on mainly? So, in your
Mm-hmm.
cookbooks, when you are talking to diabetics and you're trying to set them up, I'm assuming you're changing it from person to person.
Exactly. The biggest thing is being individualized in the education I provide and also meeting patients where they're at because people have different constraints. I go through social determinants of health. I do a screening and then I try to figure out what are factors that might impact their diet. And then I do dietary recalls. And then I pick out in those recalls what are areas that could that they could improve. And then I ask the patients, I go, okay, well, here's some things that I'm seeing that we could work on. What do you feel comfortable working on? What's the easiest thing for you to get started? Because, a lot of times patients feel very overwhelmed. Not only are they told you have this new condition, but it can be very alarming and jarring, especially if you're told now you have to take insulin. So the diet is a very big component, and people come see me without even knowing my background in food. And the first question they ask is, what do I eat? So I think what it is just going through their diet and saying, okay, I see that you're skipping breakfast. Tell me more. How can we get you to start eating breakfast? And then providing ideas based off of the food choices that are available to them and what can be easiest for them to make a change on.
Sure, that makes perfect sense.
Mhm.
Do you find that a lot of the people who come to you just have no clue what to eat, especially given, I mean, let's face
Mm.
it, you look at advertising today and it's junk. It's junk, 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 left and right. You were talking about social determinants of health. And I've recently
Mhm.
written a chapter of my forthcoming book on diabetes and nutrition, and it's mainly about type 2. That chapter is, and one of the big things is obviously what type of foods are available to you. Do you live in a food desert, which is a major
Mhm.
problem, especially in a lot of inner cities? If you could just speak to some of that, I'm interested in knowing more about the social determinants of health that you brought up.
Absolutely. So if someone screens positive for something like healthy food access, then I'm going to dig into why and talk about the options that are available to them. So we have the Minnesota Food Helpline that I can offer right then and there. They speak multiple languages, but we also have other programs that I try to coordinate through our clinic. So there's one called Brightside Produce. I will get them in touch with Brightside, and basically it's like a produce delivery system. So our patients are offered a special lower rate to get fruits and vegetables delivered to their door. And I'm working on other programming. This summer, we're starting a garden series. It actually starts next week. So patients are going to be able to come to the garden, learn about food, take the food that's grown out of the garden, and then meet some of these partners as well.
That's amazing. Yes, I know this is a huge problem. It's just access to healthy food is such a major issue. You talked
Mhm.
about diabetics coming to you, and some of them have to go on insulin. How
Mhm.
does how have you seen that kind of change for patients, patient to patient, going from say being maybe on a sulfonylurea for type 2 and all of a sudden they get told by their endocrinologist that they need to be on insulin injections, which of course, for those who don't know, is what type 1 diabetics have to take from the get-go. That's what I've been on for almost 29 years, and it's, I mean, let's be blunt. Being stuck on insulin is hell. So what is their response?
Yeah, it's in general, I would say most people view it as a failure, and it's so hard. I see everybody, they walk into my office and their head is hanging low, and so it's really about trying to change their mindset and explain the pathophysiology behind diabetes and explain that it's nothing like there's a lot of factors that are reasons why people might develop diabetes, especially type 2 diabetes,
Right.
where they feel like it's a personal failure. And so I point out here's all the things that we look at that can cause diabetes. And even the simple statistic of if you have a generational history of diabetes, it takes 3 generations to get diabetes out of your gene pool.
I didn't
Um,
know that. Okay,
but
that's fascinating to know. Did not know
three
that.
three generations. So if you're within that in that time period, you have a 40 to 60% chance of getting diabetes type 2.
Yeah.
So that's pretty high. So just think if you're working really hard to have a good, healthy life, but you still get type 2 diabetes, because I do have patients who come to me and they say, I don't get it. Why? What happened? And then if they're being put on insulin, then we have this discussion of, okay, well, that doesn't mean that it's permanent. The quicker you get your blood sugars in control, the less likely you are to stay on insulin for life. Now, I try to put things into perspective and just say this, everybody's independent. We don't know what's going to work for you. It might work for different for someone else. So it's really good, I think, expectations to lay that out in front of the patient. But some of these medications, there's a wide variety of them available. And they're getting better and better all the time. But again, a lot of the patients I see, they're mostly people of low income, no income, insured, underinsured. So we're working with a lot of drug assistance programs and also programs within the state to get them coverage.
Yeah. And I mean, I think that if I have one bit of advice for all the type 2 diabetics out there, it's that if you can find a way, whatever way it
Mm-hmm.
is, to get off of insulin, if you go onto it, absolutely do so. I mean, I know it can be difficult. There are genetic factors involved, which are very difficult to overcome. But
Mm-hmm.
the last thing you want to do is transition into a type 1 diabetic.
Well, I think that if you can try to find a way
Yeah.
that we can get your body to make its own supply of insulin and not being reliant on exogenous insulin or injected insulin
Right.
that you do yourself, yes, we want to try to get your body to be working like it should. Now, all medications, they all target different organs, and the idea is that they target your organs in a way to help control blood sugars, but they all have different pathways, and some of them work better together. And some of them have added benefits. Some of them have CVD protection, some of them have kidney protection. And so, if a doctor is telling you you need to be put on insulin, ask them what are your options and why are they recommending insulin at that time. I hear from both. Like I have some providers who are really hesitant to prescribe insulin, and I have others that are saying, yes, let's do this. So it really depends on who your providers are
Are,
and their
yeah.
knowledge on the medications that are available.
Sure, sure. Are you seeing a lot of the type 2 diabetics being put on CGMs, continuous glucose monitors,
Mm,
maybe first, before they or maybe transitioned over to insulin? Are a lot of your type 2s
mm.
wearing CGMs? Is this not available to them because of, lack of insurance?
That is mostly it.
Okay.
CGM access is quite limited to those that have insurance, although some of them are paying out of pocket, but the cheapest one you can pay for out of pocket is still $75 a month.
Right.
That's a lot of money. I
It's
mean,
expensive to be a
but if
diabetic, as you said.
it's very expensive. The last statistic I saw, I every year I look for a new statistic on the cost of what diabetes is on a person, and I still haven't had an updated number, but from 2017, I know that it was just over $16,000 extra if you had type 2 diabetes. So that's 9 years ago.
Yeah.
I mean, and think of inflation. We know that cost is a lot higher.
Yeah, yeah, no, it's crazy. I mean, I know just for type 1, and of course, the number of type 1s in the United States is, very, very small. It's about 2.1 million nowadays, as compared to the not only the type 2s, but the pre-diabetics. And
Hmm.
I mean, we're looking at, what, about 30 million people who are diagnosed with type 2 and another up to 90 million who are pre-type 2. The numbers are
Hmm.
staggering. This is a public health crisis of alarming proportions. And I think that we don't talk enough about it because there's this shame that goes with being a diabetic. As you said, I felt shame for
Hmm.
years. I didn't want to tell anyone I was a type 1 diabetic. I lost a job because they tested my urine when I went in for the job interview. They tested it before the job interview, and they said, "Are you a diabetic?" And I said, "Are you kidding me? You're not allowed to ask that." I didn't get the job as a result.
Wow, I am shocked. I can't believe that happened.
Oh, yes. There's a because also there's a not only is there discrimination, but there's just a complete misunderstanding of what
Mm-hmm.
diabetes is. And again, there's this stigma. There is a
Yeah.
stigma that goes along with it. So
Oh, I know. You can't look at someone and see if do they have diabetes or not. No, you can't.
no, not
You
unless my
have to
glucose
test the
alarm is
blood.
going off.
Exactly, exactly. Like we have to test people's blood sugars to know are they being able to control it because a lot of times people, I go through all the different things that affect blood sugars and people usually just think it's diet related, but it's more than diet, all right? We know that genetics factor in. Of course, we
Right.
talked about that. We know that lifestyle when it comes to exercise, but even poor sleep, high stress, those can lead to diabetes too. And we're not talking about that.
No, it's just, oh my gosh, how did you let this happen to yourself? Shame on you. That's usually the reaction,
Yeah.
and why
And
so many people try to hide it.
mm-hmm, right. And when you have that shame, how are you supposed to get better? How are you supposed to get the help that you need? Because and then when you feel that shame, you're not going in for your regular appointments. And when you have diabetes, you have many more appointments because you want to try to prevent those complications from happening. And they
Right.
happen.
They do.
Like diabetes is a progressive disease. Even if you have it really well controlled, it can get worse, which is why you have to keep going in. And it stinks. Nobody wants to come to the doctor every 3 to 4 months. That's not fun. But it's really important to keep those appointments to make sure things are still running smoothly.
Right. Absolutely. So, all right. So
Mhm.
CGM's not really available as much as we would like them to be.
Mhm.
CGMs to me are the biggest game changers since the discovery of insulin by Banting and
Mhm.
Best in the early 1920s.
Mhm.
They are amazing. They're truly amazing. What they allow you to know constantly about your glucose without having to constantly prick your fingers, which was the most painful part of diabetes. Um, that they have done tremendous things, and
Mhm.
they're continuing to do tremendous things. But there's always the affordability issue. And like you said, diabetes is expensive. Tell me about GLP-1s. What are you seeing in terms of your patients using the quote unquote skinny shots?
It's very tricky because number one, a lot of patients who are put on those medications do not see a dietitian and they really need to because there's a lot of things nutritionally that they need to make sure they're getting because in the absence of food, then how are you getting those vitamins and minerals? As well as having proper hydration.
Right.
So, yes, I see a lot of our patients get prescribed GLP-1s, but it doesn't mean that they're open to it, number one. So, it's a conversation with the patient about the pros, the cons, here's the side effects, how do you feel about it? I know that they're getting pushed for weight loss, and we know with weight loss, we typically see improved blood sugars. But it's also important, again, to put it in perspective to a patient, like when this is not a medication that you just start and stop. This is a long-term medication for management.
Right.
And so it's having that conversation with the patient. I would say maybe because of the positive benefits of these medications. They get prescribed quite often, but again, it comes down to coverage. So if we can get a patient on a drug assistance program, we'll go that route. But I like to just tell patients, I just tell them this is the pros, the cons, this is what you're dealing with. I want you to decide because ultimately, it's them, it's their body. They have to know what they're getting themselves into.
Sure. Sure. Yeah, that makes sense.
Mm-hmm.
And we,
Mm-hmm.
because they're so new, we don't know the entirety of the side effects of these. I was recently speaking to my dentist, and he said he's seeing people coming in who are on GLP-1s who are it's causing gastric distress, and as a result, their teeth are being eaten away
Mm-hmm.
by the severe gastric reflux that's occurring. So again, we just don't know when things are this new. We truly don't know what the long term consequences are going to be of taking them. Let's turn a little bit more to the human side. of your work as a diabetes education specialist. What have your patients taught you about living with diabetes? I'm assuming that you don't
Mhm.
have diabetes. Is that correct?
Correct. I don't have diabetes, no, but a lot of my appointments they get really emotional. So people really do break down the wall and expose a lot to me, and I feel so very like privileged to be part of that, and be part of their life to help guide them through this hard time. It's a lot of times it's very challenging or hard for a person to be diagnosed and to go through it, but having patience and it's interesting because when I first got into this, I was thinking, why can't people make the change? This seems so easy. Like if they just did the things I told them to do, then this would all work out really well. But that's not the reality of things. I've asking a patient's like, okay, we talked about this. Why did you do this? No, why not? Like really, but coming at it from like a, a non-judgmental approach and just saying, hey, what's going on? Let's chat about it. And then we learn, oh, maybe there was a death in the family or they're dealing with depression. 1 in 5 people with diabetes have depression. And so we have to really think about, okay, what is the roadblock here? Why is this hard for you to overcome this hurdle? And so it's, you know, digging a little bit deeper and using some motivational interviewing skills along the way. So, yeah, really just getting personal with patients. I mean, sometimes it's emotional. A lot of times it is. Like we cry together.
Right. Yeah, I remember when right after I was diagnosed, I was diagnosed when I was in college, and then I was in DC working for the American Diabetes Association, and
Mm,
I was at a bookstore. I don't remember what branch it was, or maybe it was a Barnes and Noble, um, and I found a book. I was just browsing, and I found a book that was "You Are Not Your Disease," right? And
mm-hmm.
I kind of took that to heart, and but to me, I did probably the wrong thing. I said, well, yeah, I'm not my diabetes. And as a result, I'm just going to hide it and not let anyone know that I'm diabetic. And I think that was the wrong approach. Um, we've talked about people feeling ashamed, and that can lead to depression. What other emotional challenges do you feel like newly diagnosed diabetics face?
Well, I think that sometimes people just don't want to make a change. They don't want to change their diet. They're like, I love eating the foods that I want to eat, and I don't have any intention of changing that. And
Right.
so that can be really tricky. And so the way that I approach it is I talk about like the benefits of even just one small change and what that could do for them. And then getting them to notice the difference in how they feel, because I don't know that enough people think about how food affects their body. And I also get patients to pay attention to the times their blood sugars are in a normal, healthy range, right? Like the goal range we give them. Because sometimes, let's say they come in and their blood sugars are over 300. And that to them felt normal. But then we get their blood sugars down to maybe like 140, and they go, wow, I have energy. I can sleep. I didn't even realize. And so I always ask my patients, how do you feel today? How have things been since we spoke? And a lot of times they're telling me, and I go, oh, yeah. So what changed? What was the, and so they'll make one little change and then they'll see it, they'll feel its effects. And then it snowballs and then it gets, they start on something else to work on that, gets them even closer to goal. It's great. I love seeing that transformation happen in a person.
Absolutely. Absolutely. I could not agree with you more. Are there any stories or like personal or specific stories from any particular diabetics that, you
Mm.
know, really kind of, I don't know, made an impact on you, positive or negative?
Mm-hmm. I mean, I've just seen people make incredible changes in their diet and lifestyle. I had one patient who came to me who didn't know anything about nutrition. He just says, I don't know what a carbohydrate is. protein, fat. I don't know what any of this is. He just said, this is what I eat, this is what I drink. And, he at first he wasn't including his alcohol consumption. And I go, let's talk about your beverages. What are you drinking? And then I go, but what are you drinking on the weekends?
Right.
And I learned he was drinking 6 to 12 beers a day on the weekends.
Oh
And then
my
every
gosh.
meal, it was 6 to 8 tortillas. So every meal. And so I just showed him the numbers and I go, this is how many servings of carbohydrate you're having. This is how many is recommended. And he was so floored. He goes, wow, I had no idea that this is what. And he goes, yeah, I have no problem making a change. Like he cut him out. He cut down his tortillas. He didn't cut them out completely, but he did stop drinking. And when he stopped drinking, he goes, Ranelle, I have so much energy. He goes, I'm going to start playing soccer again. So then he joined a soccer league.
Okay.
6 months later, we got him to goal. His A1C was over 12. We got his A1C less than 7% in 6 months' time.
Excellent.
It was incredible. I mean, and he did so much of it on his own, and I just kind of helped him along the way, but he did all the hard work.
Oh my gosh. Over 12 alarm bells are going off.
It's it just
You're going to go
shows you.
blind. You're going to lose. You're going to have amputations. You're going to have kidney failure when you're over 12.
I know, and sometimes I have to use scare tactics. I don't like to, but when I have patients who see me time and time again who are just not getting any progress and their A1Cs stay over 10,
Right.
I have to have a very hard talk with them and I say, "I'm sorry. This is the reality you're facing. I don't want this for you,
Right.
but this is what the data is telling us is likely going to happen.
Yeah.
And it stinks. It's hard to have those conversations, but when you really see a patient can't, and then digging into why and finding a motivation to reason to get them on track, to get them to start to care.
Absolutely. Yeah, I mean, that's the big thing is with diabetes, many times you go in, like you said, you have to go to the doctor, once every 3 months, and that's a burden. But the rest of the time, it is up to you. And that's such a huge burden is managing yourself in between and staying on track, staying on course. If you don't have the, willingness to do this, it's simply not going to happen. Those how often do you meet with your patients on average?
Well, if their A1C is over 9, my goal is to see them every 2 weeks.
Okay. Okay, good.
That's the policy that we have because we know through so we do a lot of quality improvement projects and get a lot of grant funding. And we've seen huge improvements in people's A1C numbers if they come in for a visit every 2 weeks. And it doesn't necessarily have to be with me. It could be with a nurse or a provider, some medical professional that just addresses blood sugars. But we
Sure.
know we can get their blood sugars down when we have these frequent touch points. I think we saw an improvement of set 2.7% A1C lowering just by having that frequent contact.
Wow. Wow. Yeah.
Yeah.
I mean, they're afraid to come in and face the wrath if they haven't been doing what they need to do, which is good. I
Yeah.
mean, people need that motivation.
They do. Especially in the beginning too, because sometimes, like you had mentioned, you might retreat when you hear of a new diagnosis and you think that there's shame behind it. But we really, right in the beginning, that's when we really have the most impact at lowering the risk for those future complications.
Right. Right. Would you like to speak a little bit about how just overall difficult it is to manage diabetes? The reason why I bring this up is that there's a recent documentary on Netflix with Charlie Sheen where he talks about his HIV diagnosis. And he made a
Mm,
very important distinction in there where he said that with the medicines that they have for HIV nowadays, it's much easier to manage HIV, or at least in his estimation, it's potentially easier to manage HIV than to manage diabetes. And I heard that and I went, yeah, it's actually, I mean, I don't have HIV, thank God, but as far as I understand it, as long as they are able to, as long as they have access to the medicines that they need to suppress the virus, that's basically all they have to do.
Mhm.
As opposed to diabetes, where you're constantly measuring your sugars, you're constantly having to watch what you eat. Would you like to speak to that?
Yeah, I mean, yes, because there's this burden. It's this having to check your blood sugars all the time. Like there's exhaustion that happens with people. And I see people go through cycles of doing really well, and then they're just tired of testing their blood sugars 4 times a day. That's a lot, but for some people who are on insulin multiple doses a day, that's the recommendation. That's what we want you to do to be safe. So it does. I do see people go through these cycles of doing really well, and then they get sick, and then they feel like they have to start all over again and try to get back to their blood sugar goal. But in some ways, it's becoming a lot easier to manage too, because we have a lot of tools at our disposal. Within some of those CGM applications, for the people that get access to them, they have programs where you can snap a photo of your food and it tells you what order to eat it in. I
Yeah.
mean, so it's getting easier, which is great. And we have, closed loop insulin systems so that they can be, their CGM speaks to their insulin pump. I mean, how incredible. And we're also seeing, I mean, I guess I'm jumping ahead a little bit, but even there's medications that are helping prevent the onset of type 1
I know
diabetes.
Tzield just got approved, which is very
Yes.
exciting. Yeah.
It is. I spoke with the one of the head endocrinologists. She presented a couple of times at some conferences I was at last year, and it's so phenomenal. I really it's if you could put off type 1 diabetes even a day, even you would, wouldn't you?
Oh
I
my
mean,
gosh. I'm always saying I would love a vacation. I don't care how long the vacation
yeah.
would be. I would love a vacation.
And that's, you bring up the perfect point. You can't take a vacation from this. Once you have it, and you have to manage it. But I think it's really important to also think about your support system around you. If you don't think you have support to help you manage your disease, you got to find it. There's a friend, a family member, someone within your community, your healthcare providers. Like a lot of times we offer support groups within our community, and it's just a means of asking, because
Right.
there's a lot of things to talk about in a visit, and we don't always get to talk about everything that there is open or available to you.
Yeah, I agree. Again, I'll go back to CGMs and just how important I think that
Yeah.
they are. And if we were able to get CGMs, I believe Abbott has a program where
Mm.
they're providing CGMs to their Freestyle Libre CGMs to people who can't afford them. I would need to look more into that, and I'll be at a conference here in a week where Abbott's going to be there, and I plan on talking to them about that. But
Yeah, well, they do offer a 2 week trial. So
okay,
anyone can go online and get that. And it's really easy just to ask for a sample yourself as a patient or a person with diabetes. That's something we also offer through our clinic. So, for example, if we're trying to get someone on one, we'll say, hey, why don't you just trial the CGM that we have? And we do use the Freestyle Libres, they are the more affordable
yeah,
CGMs on the market.
and they're
Hmm.
smaller. I mean, I know Dexcom has a brand new one that's coming out that's smaller, but right currently the Freestyle Libre 3 Plus is about a third the size of the current Dexcom. So it's a huge difference. It's such a
Oh,
huge
yeah.
difference that like when you roll over on it at night, if it's on the back of your arm, it won't wake you up. The
Hmm.
Dexcom will wake you up when you roll over on it.
Hmm. Well, and there's another FDA approved CGM that also has the ketone testing.
Yes, that's the new Abbott one, correct?
I believe so, but I'd have to double check.
Yeah, yeah. The pharmaceutical companies are gonna watch this and go, oh, "What are they talking about? No, it belongs to
Yeah.
us." So they can leave a comment. Um, so, what advances are you most excited about in diabetes care?
Well, I am excited about some of these medication advances and also I'm actually really excited about the ketone testing with the CGM. And in particularly because I think of our patients who are pregnant with diabetes or GDM, gestational diabetes, as well as type 1, who, let's face it, are not testing ketones. And so ketones are something that we really want to test when blood sugars are high. And we have the ketone testing that you can test through your urine, but it's not as accurate. So with the CGM, it improves the accuracy and can really help prevent the onset of diabetic ketoacidosis.
Which is terrifying
So
and terrible. Yes.
yeah, I hope you haven't experienced it,
No,
but I know a
well,
lot.
I don't know if I have. Maybe when I was first diagnosed, I did and
Hmm.
didn't know it. But no,
Hmm.
I have not experienced it since.
Well, yeah, it's really it's hard. Most people or a lot of people get admitted to the hospital, to the ER, and you need to treat with insulin because your body's not actually making insulin anymore. It's just breaking down ketones for energy. Not something we should be doing. It just makes a really acidic environment for the body.
Right, right. Yeah, that we don't want excess acid in our bodies. That's for sure. Don't want that at all. Um, Here's another question. You get to put on your prognosticator hat.
All
Where do you
right.
think diabetes care is going to be 20 years from now?
Wow, 20 years. I really hope we see lower rates of diabetes. We really need to target prevention. I don't think we're doing enough with prevention. So my hope for the future is that we're really targeting this group of people with prediabetes or who are just healthy people without prediabetes, even. But looking at more advances in technology, even on how to look at someone's diet and to make suggestions on how to improve and when to improve. And we're already seeing this happen. I mean, even the use of AI with, you could use AI to try to help with your diet, right? I'd still work with a dietitian because dietitians are the experts, but it could be a really great starting point too.
And it's so easily accessible.
Mm-hmm.
Anyone with a computer or a phone, a smartphone, can go on ChatGPT and ask for a little bit of help.
Mm-hmm.
Yeah.
Exactly.
Okay, speak a little bit more about gestational. I feel like gestational diabetes is
Yeah.
the forgotten diabetes. I mean, in terms of, you know, obviously, if you're a man and you're
Mhm.
not around a woman who's pregnant with gestational diabetes, it's the one that I
Mhm.
think tends to kind of get overshadowed. But tell us about your experience with gestational.
It's very serious, and so we categorize it a little bit differently. So it depends if you have type 1 or type 2 and then you become pregnant, then it's diabetes in pregnancy. And then gestational diabetes is when you develop diabetes during that gestation period of when you're having your baby. And so this is, a lot of times when patients get referred to me, it's not, I usually don't, I want to see them as soon as possible, but the reality is I'm not seeing them until like close to the end of their second trimester. So, we work on diet, but it's when you're in the second to the third trimester, your insulin needs double and triple.
Wow.
And so that's very hard for the body when you have gestational diabetes to try to make enough insulin to lower your blood sugars naturally. So again, for people on listening, in order for our bodies to, lower blood sugars, we need insulin available to lower it. But if our body is needs more production of this hormone to in order to bring down the blood sugar, then it's going to be staying elevated for longer. And so basically, we see these complications that happen both for the mother and for the baby. And so we try to talk about what are the risks for each, and that we need to get their blood sugars in control as possible. And it's a much tighter range when we have someone coming in with gestational diabetes and pregnancy. We need to get their blood sugars even tighter. So we want them around 90% time in range if you're using those metrics. And unfortunately, we don't have approval, FDA approval for CGM use in pregnancy, but I'll tell you, a lot of practitioners are using them. They're really helpful tools. But technically they're not listed if you look at the standards of care in diabetes.
I know there are a lot of biohackers who are wearing CGMs. They're somehow getting their hands on them.
Hmm.
But yeah, it's crazy that it's not approved in pregnancy for
Hmm.
gestational. That is
Unless you have
shocking.
type 1 in diabetes.
Yeah, because then it's diabetes in pregnancy, as
Yeah,
you said.
exactly.
But if you've
Hmm.
got type 2 and you get
Hmm.
pregnant, then it's
Hmm.
it's not approved.
No, I know. It's just like we need to have some kind of, I don't know.
Who's
It
making these
just, to me,
decisions? Who's making these decisions?
I have a feeling it's a combination of insurance companies and trying to catch up with the science and not being able to study these populations as in depth as we'd hope to. It's a lot harder to do research on pregnant women.
Yeah,
So
yeah.
it takes longer.
I understand. So tell us about the complications that come from having gestational diabetes, both for the mom and for the child.
Yeah, so for gestational diabetes, it's really going to be for the woman, it's going to be around risk for preeclampsia, which is really when your blood pressure spikes really high. You're more likely to have a cesarean delivery because the baby tends to be large for its gestational age. And so the baby is going to be weighing a lot more. There's more of like a preterm, so they're going to be delivered sooner. And because you have to think of their growth rate. Also, so yeah, so I talked about some of those risks, the large for the weight and the size, as well as some of neonatal and fetal risks. So super important that we really try to limit those as much as possible. And a lot of times we're monitoring the baby and the mother more frequently too. And so you absolutely should be working with a specialist and a high risk OB.
Is there a
Mm-hmm.
higher percentage possibility that the child will develop diabetes
Mm.
if they're born to a mom with gestational diabetes?
Um, well, we know genetically if someone has diabetes and then their offspring has it, then yes.
Okay. Okay.
Yes. But when I don't think a lot of people realize too, if you have gestational diabetes or diabetes in pregnancy, your only good option for medication is insulin because
Oh.
they cross the blood-brain barrier. So that means that the baby is getting access to these medications as well. So that's why we don't recommend oral medications in diabetes. We really, or when they're pregnant, we really need them to be taking insulin. And so sometimes, you see very extreme. You see some patients who are like, great, if that's what my baby needs, I want what's best. And other people get really freaked out. And then what I find is that these patients will stop eating because they don't want their blood sugars to spike. And they'll go, look, I'm in range. And I go, well, we need you to be eating because we need to make sure your baby is nourished and you're nourished. And so it's really hard to manage. I mean, it's in reality, it's 3 meals a day plus 2 to 3 snacks. And that's
Right.
a lot for people who have a work schedule if they're working 40 hours a week to try to have a snack and if they're pregnant,
Yeah, and
harder to manage.
with diabetes, it's like one
Yeah.
thing leads to another, and
It
you do
does.
one
It
thing
does.
to prevent this, and something else happens because of the treatment that you're using. So
Hmm.
you try not to eat because you're trying to, get your blood sugar under control, and oh my gosh, the baby's not is being malnourished.
It's very tricky. I know. And so when I work with a patient who has gestational diabetes, then I try to meet with them every week if possible. So I have slots in my schedule for high risk GDM patients.
Yeah, absolutely. I think that's the best thing that you can do, and it's great. It's great for mom. It's great for baby, and baby can thank you later.
Hmm. Well, and so I bring this up because we don't have a lot of endocrinologists to be seeing these patients. We really do need more diabetes educators, CDCESs is the new name, to really be taking on some of these patients. And you're going to be finding these people in various settings. They're not just all in endocrinologist clinics. But we're going to see them in other specialists. So I think it's really important that if you get diagnosed, that you find a diabetes educator to work with because the risk is so high.
Right. Yes. You need to be talking
Yeah.
to someone who is an expert in diabetes and diabetes management. And if you don't have
Mhm.
that, and you're either you then know nothing about what's going on, or you think you do, you never know
Mhm.
as much as you think that you do, unfortunately.
Absolutely. And the great thing too with telehealth, so actually 75% of my visits are done virtually.
Wow.
And that's because I'm just trying to meet my patients where they're at. And that's what works for them. So I'm trying to say that as there are options out there for people. Like if, you can look at what virtual options are within your state if you can't find someone that's local to meet one on one in person.
Sure. Yeah, that's great advice. That is fantastic advice. It's better to talk to
Hmm.
someone no matter what format it is than to avoid
Hmm.
talking to anyone. So,
And they're more affordable in small community clinics. So I work at a small community clinic. They're called FQHCs, federally qualified healthcare clinics. And they really are these clinics that are embedded within the community. And a lot of times they fund physicians like myself. So a lot of
okay.
patients are getting free services to come see me.
Yeah, that's
So,
fantastic. That's fantastic.
mhm.
We just need to get them to actually come see you. That's the key.
Exactly, exactly.
That's the key. Okay, so some other some other questions that are more from a historical perspective, since I'm a historian. Um, what do you think people 50 years from now will find surprising about how we treat diabetes today?
Wow, good question. I mean, could it be related to the diet? I want to say something related to the diet. I feel like there's probably a hack. There's got to be a simpler way that we can look at the diet, and we're going to be able just to, I hope, just know exactly what to do different or a change we could make. That's a really good question. I feel
Yeah,
like I need to think on this more.
I'm just thinking of historians looking at diabetes. Hopefully, they're writing a history of diabetes as a conquered disease 50 years from now, and seeing how
I hope
we're
so
discussing it
too.
today, I think would be just kind of an excellent, you know, oral history archive for them to look at.
Or maybe there's another marker in our genetics or in our blood that we could look at and test and see what is our risk level, and then being more preventative or just saying, oh, let's try not to turn on this gene.
Yeah,
When we get into nutrigenomics or nutrigenetics, it's that study of like how nutrition affects our genes and whether they're turned on or off. So
right.
I like to think of it, maybe there's a way that we could look at not turning on the gene that causes diabetes, for example.
Yeah, let's turn off the bad gene because it is a
Yeah, turn
bad
it off.
gene. There's no way to sugarcoat it. So yeah, that's great. So so if you're looking at again the future, what do you
Hmm.
think is misunderstood about diabetes today that future
Hmm.
generations should know?
Hmm. So something that the future generation should know.
Yeah, so in other words, what's the
Hmm.
biggest misconception about diabetes today that people looking at it, let's say in a post-diabetic world, or in a world where at least now you get it, we can cure it. Um, what do you think what do you think we most misunderstand about it today? That
Mm.
that if they were looking back on it, they go, oh, wow, they had that really wrong on the whole, or she was truly Nostradamus in diabetes educator form.
Yeah, I mean, number one, I just think that we can't look at someone and then say you have diabetes. I feel like we do that a lot, just judging off people's appearance. If someone is overweight, they'll say, oh, you have diabetes, or they'll treat them like they have diabetes.
Mm.
And we know that's not true, but I'm hoping that in the future, we won't have that preconception that just because someone is maybe a little bit heavier, that automatically that they have diabetes. It's much deeper than that.
Well, I had a doctor who was not an endocrinologist one time look at me and say, "You don't look like you have diabetes." And I said, "Do you know the difference between type 1 and type 2? And also, by the way, do you know that there are a lot of type 2s who are thin?" And
Yes.
and so that actually has, very little to do with it. And this was coming from a doctor. This was a medical doctor.
Oh,
And you should have seen the look on his face when I, shot that back. It was
I'm
just
glad you did
horror
that.
and terrible embarrassment is what it was.
Yes, I'm glad that you did that, and more people need to do that and call that out because that's not appropriate, and they should know better.
Oh, and how did you get through medical school? I don't care what your specialty is. How did you get through medical school not knowing about diabetes, especially with, the impact that it's having?
Diabetes is such a big topic. I mean, there's a reason why people specialize in it. So again, I think it's so important to be working with the experts in the field because I think about this a lot actually when working with general practitioners. They have just they need to have general knowledge of so many things, but I'll tell you, they don't know most of the diabetes medications. Like they know like maybe a drug, like one drug within a drug class, but they're not
Mm-hmm.
staying up to date necessarily like I am. Like that's my job is to look for all the new medications and educate them on it. So I'm always trying to talk about like the risk benefits of all the medications out there, but a lot of times it's news to people. They're like, "Oh, I didn't know that." And that's fine, but I think it's important that providers be open to hearing what a diabetes educator has to say because there is this hierarchy that is experienced sometimes in healthcare where people don't want to talk to dietitians or diabetes educators because maybe we don't have the pedigree of MD behind our name. And I think things are changing, but I've just experienced it quite a bit in my profession.
Well, as I tell people, what PhD behind my name means is simply piled higher and deeper. It doesn't mean that I have any real, extra expertise. It's just that I basically was able to stick it out when others couldn't. But
Mm-hmm.
in your case, I mean, you decided to do this as a way to get people to think more about their diet, which is
Absolutely.
fantastic. So tell me
Hmm.
more about your books.
Oh yeah, so I wrote both of these books out of response for trying to combine all my passions into one thing, really. So I used to teach quite a few classes, cooking classes, and integrate nutrition into them. And so this is my way of taking all of these cultural experiences I had because I'm a big traveler and I love meeting people. And so these recipes were inspirations from basically my life building up to now and looking at things like how can we have a varied diet, make it exciting, because people just think that healthy food has to be boring and salads, and I'm like, there's so much more exciting things about food, so let me show you, let me teach you. So I wanted to be able to take some ideas that you think are like, I could never make that. That seems too complicated. And it's like, well, no, it can be very short, easy. You can make some substitutions. So teaching people how to do that. And working in these settings where I've instructed people on how to make food, it's so interesting when people read a recipe, how some people are just so glued to that recipe. But I really try to encourage people to take a step back and think about the recipe in the sense of, okay, if I don't have rosemary, do I need it? Could I substitute it with something else? And so just getting people to think about that more. So
And where can people buy your books?
Yes, both books are available on Amazon. And I know that there's a couple of independent bookstores in Minnesota that also sell like subtext books.
Okay. And
hmm
if anyone watching this wants to follow you and see what you're doing, where should they find your social media contacts?
Yeah, so I'm on Instagram and Facebook at Ranelle.Kirchner. That's Ranelle period Kirchner.
Excellent. Well, this has been incredibly eye-opening for me. I've learned a lot. I tend to get myself dragged down into the type 1 diabetes hole, and I've been doing my best to learn as much about type 2, but I've learned a tremendous amount about gestational today as well. Anything else that you would like to add that I haven't touched on?
Well, I just want people out there to know that if you have diabetes, whatever form it is, there's help out there and we want to help. And it's a roller coaster. And it's just good to acknowledge that, but know that there are people that do want to help you. And there's a lot of resources out there. And so just get in touch with your healthcare providers. We can help you. We want to help you. And there's a lot of free education out there too. Just make sure you go to the expert and not try to Google things or try to search things online to see what's the best. Ask the expert.
Don't ask WebMD.
Yes, always. You can, if you wanted to do a general search, just verify with your expert, dietitian, diabetes educator, provider, endocrinologist.
Right. That's fantastic. Thank you so much, Ranelle.
Thank you for having me, Brian.